Hi, I'm D'Angela Pitts, one of the MFMs at Henry Ford Health System and one of the former Queenan Fellows in 2018. I'm going to talk to you today about neonatal healthcare shortage in the global health setting, how increasing educational opportunities may impact neonatal care and outcomes. My co-authors are neonatologist Dr. Kakura at University of Michigan, Dr. Moravia in Annapolis, and Dr. Johnson at University of Michigan. I have no conflicts of interest to disclose. Today we're going to talk about the problem in global neonatal health care, address the challenges to building capacity in low-middle income countries, where are we now, and what are the next best steps. Martin Luther King Jr. said it best: justice denied anywhere diminishes justice everywhere. And injustice anywhere is a threat to justice everywhere. As a perinatologist, why do we need to focus on neonatology in the global health settings? As of 2017, 2.5 million infants died in the first month of life alone, and neonatal deaths comprise of 46% of deaths in children under the age of 5 years old. Prematurity was the leading cause, and majority of that occurred in low and middle income countries. When looking at the data, 2/3 of the deaths were attributed to the lack of quality of care in the perinatal period, which is a modifiable risk factor. The WHO developed goals to address specific problems affecting the world, including improving maternal health and reducing child mortality. When taking a closer look at the WHO Millennium Development Goals, at childhood mortality, there was a decrease from 1990 to 2016. In 2013, 6.3 million children under 5 died compared to 12.7 million in 1990. And their under 5 mortality declined by 49% from an estimated rate of 90 deaths per 1,000 live births to 46 deaths per 1,000 live births. And then when looking at the graph to the right on the screen, you can see that majority of the deaths occur secondary to prematurity and acute respiratory infections. Despite this improvement, we have not reached the goal of child mortality under 5. Thus, we have some work to do. And though in the United States we do not boast the best infant mortality in the world, there are many nations in which infants fare much poorly. In Ghana, there are 34 deaths per 1,000 live births, and in Ethiopia, nearly 50 newborns per 1,000 do not survive infancy. Where you live matters, but there are challenges everywhere. And while I think that many Americans imagining the high neonatal mortality in Ethiopia think of the top picture, it is important to note that even in an urban environment like Addis Ababa, it's still a serious problem. Infant mortality in rural areas are 10 times greater than infant mortality in the United States. And in those urban areas, it's still 6 times higher than the United States. And though it's hard to find exact data, partly because of the challenges in collecting neonatal outcomes, along with any birth outcomes, estimates are as high as 77 deaths per 1,000 infants in rural areas in Ethiopia, and 20 to 30 deaths per 1,000 infants in the major city hospitals. And this challenge exists because there are variations in supplies, education, training opportunities, and also the availability of providers. So what are some of those challenges? We know that neonatal care is expensive, In 2007, the Institute of Medicine found that the costs associated with premature birth in the United States was $26.2 billion each year. That's $16.9 billion in medical and healthcare costs for the infant, $1.9 billion in labor and delivery costs for the mother, $600 million for early intervention services, $1 billion for special education services, and $5.7 billion in lost work and pay for people born prematurely. But is it worth it? This slide looks at survival versus resource expenditure for the doomed extremely low birth weight infants versus the doomed adults in the ICU. 1% of 4 million infants, which is 40,000 annually, weigh less than 1,000 grams, which is less than 28 weeks gestation. And of the 3 million people who die in the United States each year, less than 1% are neonates, and the other 99% are adults. Neonates, when compared to adults with the longest stays, are typically survivors, and those infant survivors may gain many life years, while adult survivors typically get a few. So what is viability around the world? In the United States, our viability can range from 22 weeks to 24 weeks. However, many low-resource countries have nationally imposed viability thresholds at 28 weeks gestation based on arguments of resource allocation and decreased likelihood of infant survival below this gestational age. This threshold may be based on the WHO's recommendation that late fetal deaths, those less than 28 weeks gestation or weighing less than 1,000 grams, be included in the stillbirth rates. An estimate of 5.2 preterm births worldwide occur below 28 weeks gestation. However, this number underrepresents the extremely premature newborn population given the lack of consistent reporting in this gestational age range. Focusing in a bit more on global statistics, as of 2010, the global preterm delivery rate was just over 11%. However, if you look at the map and focus on the countries that are dark purple in color, those represent countries where preterm delivery rates are more than 15%. You'll note that the majority of these countries are in sub-Saharan Africa or Southeast Asia. And while delivery rates are important, survival following delivery is perhaps a more important statistic to focus on. Looking at infants born at less than 28 weeks, 90% of these infants will survive in a high-income country, compared to just 10% in low-income countries. While the lower rate of survival before 28 weeks reported in low-income nations is likely partly due to underreporting of such infants, the clear fact remains that infants at this gestational age usually do not often survive and frequently are not resuscitated in a low-resource setting. Until recently, there has been little need to challenge this definition of viability. However, with the globalization of the resuscitation technology and training, many low-resource countries will soon be able to intervene on behalf of extremely premature infants. In many academic teaching hospitals in these developing countries, resuscitation attempts in the less than 28-week range are already occurring. So how do you find the right balance? Many of the therapies critically ill infants need are not expensive in themselves. You need a delivery room attendant, neonatal resuscitation, antibiotics, IV fluids, and CPAP therapy. You also need skilled providers who are able to determine which infants will benefit from these therapies. So resource allocation and the idea of beneficence and now maleficence. When we look at global newborn health, most of the work has focused on the dying newborns with birth asphyxia, and that results in training birth attendants and simplified neonatal resuscitation. However, the problem with that is you have poor acquisition of skills, poor real-world application, and also long-term retention. Because of global health foundations and NGOs, we are now able to have the supplies needed to care for the newborns in the low-middle income countries. However, without the proper training to use the equipment and repair and maintain, this equipment falls into disuse and contributes to the growing problem. So what if we change the focus? What if we change the focus to having ongoing partnerships, targeting capacity building, and doing in-country education of subspecialties? I believe that this would be more impactful on neonatal survival than equipment and technology donations, or even the short-term neonatal resuscitation training. So the arrows that you see point to the capacity building, so building longitudinal mentoring of a fellow in their own environment, creating neonatologists that are able to teach future fellows, having self-sufficient neonatal perinatologists and the subspecialty training, and then also providing evidence-based neonatal care. So we talked about having self-sufficient neonatologists. However, the Neonatal Perinatal Fellowship, that learning opportunity varies depending on where you are. Some countries do not have fellowships and require that all subspecialist training occurs elsewhere. And others require their fellows to spend a significant portion of their fellowship training in other countries. This creates many challenges. There's a lack of formalized structured training to guide physicians. The fellows do not receive mentored ICU training in their own cultural setting. A lot of times these graduates may not choose to return to their own home and practice in their own country. And also, talented trainees may be discouraged from this training due to family obligations and unable to take significant leave. Charlotte Rent and colleagues looked at this to see why is there a shortage in trained providers. And they explored the availability and perception of global health training opportunities in the United States based on the neonatology fellowship programs. And they did this by using electronic surveys sent to the neonatology fellows, also to the program directors. There are 58 program directors and 98 fellows who completed the survey. And the fellows reported a decline in global health participation from 48% to 21% during med school to fellowship. And also fewer than 30% of the programs offer structured training and 10% offer research opportunities. The program director cited cost, scheduling, mentorship, and a lack of suitable global partners as barriers to supporting their fellows who are interested in global health training. Thus, global health opportunities are extremely important during fellowship, but only a minority engage in the work due to the challenges that we cited above. So what is capacity building? It takes a specialist to train a specialist. In fellowship, we had MFM attendings that trained us as fellows to become an attending or graduate. Academic and professional partnerships create the content and expertise for training physicians to become specialists. And this specialization brings advantages: efficiency and organization of clinical care, helps to develop policies, practice and protocol standards, allows for national research guidance and advocacy. This is one of the things that we're looking to build in our global health setting to have a specialist train a specialist. Again, it takes a specialist to train a specialist. These images are from Ethiopia, where Dr. Stephanie Kakur is teaching some of the neonatology fellows the basics of neonatal resuscitation, with the hopes that they can utilize this in their own country and wherever they go out to practice to decrease neonatal mortality and possibly lower the limit of that gestational age of 28 weeks. So this slide talks about capacity building, and it's not just one thing that needs to happen, it's multiple outcomes. So in order to build capacity, you have to have the infrastructure and the support. You have to have a curriculum development, be able to test that curriculum with a certification, outreach, because it's just not at the hospital. It's the lay person. It's the birth attendant. You need to do research and be able to publish your outcomes. And also evaluate your outcomes. How can we do better? What quality improvement can we make? So all of this together helps with capacity building. It is easier said than done. And I'm sure many people watching this presentation right now have dealt with some of the challenges of capacity building or doing global health research. So some of the challenges that can arise is, do we do new skills for the existing workers or the new workers? Do we teach the skills themselves or the skills to teach the skills? Such as, are we training fellows to become neonatologists or neonatologists to become fellowship directors? Are we training researchers in neonatal-focused projects or in research design development? And how do we measure success? How do we ensure equality in partnership? And how do we develop goals that are meaningful, achievable, and sustainable to our local stakeholders? I'm going to take a little time to talk about the Ghana partnership. So the Ghana-Michigan connection started in 1986. The University of Michigan's Department of Obstetrics and Gynecology was actively and increasingly involved in medical education in Ghana, and we noted that there was low in-country retention rates. So the plan was to establish a postgraduate training in OBGYN in Ghana and allow for University of Michigan and Ghana residents to do clinical rotations, both in Ghana and in Ann Arbor. There was a high success rate in the West African College of Surgeons board pass rate, which was increased more than 90% pass rate. So in 2016, Dr. 𝗀𝗚cy 𝗪𝗏𝗂 received the SMFM Queenan Visiting Teaching Award, and during her time, along with Dr. Johnson, helped start the paperwork and design the first maternal fetal medicine fellowship and curriculum. In order to make this happen, they identified physicians with an interest in high-risk pregnancies, and those physicians were grandfathered into the specialty. They received prior training at an outside institution, and then the MFM Fellowship accepted its first 2 fellows in January 2019 in Accra and Kumasi in Ghana. I had the opportunity to go in April and May of 2019 as a Queenan Visiting Teaching Fellow, and I assisted in making the rotation schedule, didactics, journal club, and also research opportunities, and evaluate the fellowship. This was a unique partnership. There was no medical tourism. We were able to build capacity and sustainability by going back and forth to Ghana and also allowing communication between an institution and the country. We allow visiting residents from both institutions, and the best part, we were all able to learn from one another. The images you see are from 𝗵𝗲𝗪 Teaching Hospital in Kumasi, where, if you remember earlier, I said that the neonatologists had to go elsewhere for their subspecialty training. We are currently in the process of establishing a neonatal fellowship in Kumasi in Accra. When looking at 𝗵𝗲𝗪 Teaching Hospital, looking at their neonatology, the infants are separated based on age and severity. You have a NICU term room, which houses 8 warmer beds and 2 ventilators, and usually can care for the surgical needs patients, such as gastroschisis, if a patient has pneumonia or RDS. And then you have a NICU preterm room, which has 12 isolettes and 4 overhead warmers. And you have CPAP available, however, no ventilators. And then you have your term room, which can house 30 infants and any problems they can tackle, including sepsis, hyperbilirubinemia, TTN. You have your preterm stable room, which can again house 30 infants. And then you have your kangaroo mother care room, which has 12 recliner chairs located near the term and preterm rooms, and moms take shifts doing breastfeeding and skin to skin. There's about 10 nurses that cover the babies, and they have 2 to 3 attending physicians on each day to supervise. Again, the physicians are trained all over. 1 was trained in South Africa, 3 in England, and the residents also come from the Ghana College and the West African College. Now let's talk about the Ethiopia partnership. These images come from St. Paul Hospital in Addis Ababa, and you can tell that this is a busy, crowded neonatology unit with some pictures of 3 babies to 1 isolette. And for those of you that are unfamiliar with St. Paul's Hospital, Millennium Medical College, it is a large urban public medical center in Addis. It boasts a busy obstetric program with about 1,000 infants delivered every month. It's also an academic medical center with a pediatric residency program, and University of Michigan partners with it in several medical specialties, including pediatrics and obstetrics and gynecology. 1,000 infants a month. I just wanted to point that out. So how did we build capacity at St. Paul's? We support fellow and attending education, and that's by instructing advanced neonatal resuscitation, having a visiting rotation for neonatologists to come to Michigan. However, there are challenges to developing in-country training. There's technology limitations, skilled faculty limitations, and also certification procedures. Another way we support capacity building at St. Paul's is supporting their clinical care. So providing didactic lectures, and now you can provide things virtually, which we are now all accustomed to doing, nursing education, technology implementation, and also protocol development. Going back to that Venn diagram, it also mentioned supporting infrastructure. So with that, it's administrative education, hospital planning, expanding, supporting research. So whether it's qualitative interviews, at St. Paul's, we've talked about neonatal seizure management, but also publishing that research in both local, in the country, and also on a national level. And then supporting their quality improvement, So what areas can we improve, and how can we improve with protocols specific to our environment? We spent some time addressing the problem in neonatal global health care. We've talked about the evidence and why it's a shortage of providers. We've talked about the specialist training of specialists. And we've also talked about capacity building. So what's next? Support and focus. Let's support and focus our expertise into an in-country fellowship program. However, with that comes many questions. What are the educational needs of the trainees? And what would be the requirements of certification? Where will these fellowships be? And what support do the sites need? What resources will be needed for this to be successful and sustainable? And how do we get access to them? Also, how can we include our neonatology colleagues at our institutions, at our training institutions, or even where we're working now in these discussions? And how can we, in this room virtually right now, move this forward? What steps are you going to take? I would like to thank 𝗵𝗲 African Coalition for allowing me to give this talk, and to Dr. Stringer for reaching out for me to talk about such an important issue. And always to Dr. Timothy Johnson and Dr. 𝗀𝗚cie 𝗪𝗶𝘁 for your continued mentorship and support. Thank you. The floor is now open for questions. And last but not least, these are pictures from my time in Ghana in 2019. The top picture is Kumasi and the bottom is Accra, with both fellowship programs. Both fellowship programs are thriving. We communicate on a regular basis through WhatsApp, didactic programs, and even journal clubs. And this year they will be graduating their first set of MFM fellows, so I'm very excited. Thank you.